You're listening to the Physio Matters podcast in association with the MACP, and this is session 9. Welcome back to the Physio Matters podcast with me, Jack Chew, and I'm excited to launch session 9, which is the first of 3 commissioned podcasts by the Musculoskeletal Association of Chartered Physiotherapists, best known as the MACP. I've been incredibly fortunate to meet a huge number of excellent clinical minds in my career, and since the launch of this podcast, my exposure to such free thinkers has increased further. An organisation who quickly recognised my team's main clinical goal, which is to promote honest, evidence-based and patient-centred practice, was the MACP. For many years, the MACP have been recognised as the UK's premier special interest group for specialist manual therapists, but in 2011, in keeping with the evolution of clinical practice and the evidence base, the MACP redefined its M from manipulative to musculoskeletal. Regardless of names, opinions, history and connotations, the MACP consistently advocate critical thinking, evidence-based practice and profession promotion. And that doesn't sound dissimilar to the Physio Matters podcast way at all. The first podcast guest put forward by the MACP is Dr Richard Bennett, who is a clinical psychologist and cognitive behavioural psychotherapist at the University of Birmingham. He also has a role teaching physios how best to integrate psychological therapies into practice. There's been a real increase in research linking the physiotherapy and psychology professions, but in keeping with the Physio Matters and of course MACP values, we want to see how that might best be interpreted and implemented in frontline clinical practice. So the podcast team did their homework and I travelled down to Birmingham to give the first non-physiotherapist a chance behind our microphones. So let's get to it. Hi Richard, would you like to introduce yourself for the listeners?
Yeah, so I'm Richard Bennett and my day job, I'm a clinical psychologist in the NHS. I actually work in a forensic mental health service. But I suppose the reason that I'm here is that I'm also a cognitive behavioural psychotherapist. So I'm accredited as a CBT practitioner. And I'm also a senior academic tutor at the University of Birmingham, where my job is to run a CBT postgraduate diploma. So what that diploma does is to train the folk who work in the primary care mental health services delivering CBT to people with anxiety and depression. I also do a bunch of extra stuff, kind of extracurricular activity, if you will, in my independent practice, which involves independent therapy, provision of supervision. I work as an expert witness for the criminal and civil courts. The relevant bit here again is that I do quite a bit of extra teaching and training. And in that capacity, I've recently hooked up with a local physio, a guy called Gerard Green, who works for Harborne Physio. And we've been involved in training physiotherapists both in the UK and Ireland in the use of psychological interventions to integrate into their practice. So that's largely been the use of cognitive behaviour therapy, CBT, but also motivational interviewing. So that's really the reason that I'm sitting in front of you today.
Fantastic. I'm the first non-physiotherapist on the microphones for Physio Matters. Today I'm here in association with the MACP, and that's discussing, as you said, psychological interventions in physio. And it's not that long ago it had seemed almost a bizarre statement that I'd be invited here today for that reason by the people that have been. What do you think has occurred, or what is occurring, that's made this an important topic and very pertinent topic now?
Yeah, it's interesting. I feel like I need to clear up one or two popular misconceptions if I'm the first non-physio. So I don't have a couch and I'm not able to read your mind. Right. If we can we can proceed on that basis. I think that there's two levels at which I'd like to answer this question, I suppose. And I think at one level, I'd like to say that nothing new is happening, really, because there's a couple of things that have always been true. What strikes me about physiotherapy is it's such an intimate practice. The proximity, both literally and kind of metaphorically that you have with your clients is such that I think it's a context in which people will readily share their internal world quite freely. So a number of physiotherapists have said to me in the past that they're often in situations whereby, because of the intimacy of what they're doing, people just tell them things. You know, they open up and they start talking about their concerns and their anxieties and their mood. And I hope I'm not doing the profession a disservice, but many people have said that they kind of feel a little underprepared for how to deal with those things. So I think that's always been there. The other thing that I think has always been true is this notion of yellow flags. So there are psychological factors that prevent people from recovering fully in relation to the physical difficulties that they have, or in dealing well with the situations that they can't recover from. So if we're thinking about things like chronic pain, for example, it's possibly something that's never going to go away, and so patients are in this position of having to try and make progress with regard to their physiotherapy, but there are psychological factors which are become an obstacle to that, because it's a complicated and stressful situation that they're in. And I think similarly, what many physios have said to me is that they feel like they could be more skilled, perhaps in dealing with those factors when they present themselves. So that's the first part of this long-winded answer to your question. But I think at another level, I think something new is happening, and that is that there's a recognition of the first thing. I think that it's becoming more kind of openly recognised that those things are indeed the case. That physical intervention on its own is perhaps not all it could be, and that the efficacy of a physiotherapist could be enhanced by integrating psychological theory and practice. I was struck actually listening to one of the previous podcasts with Adam Meakins, and he mentioned that this notion of the amount of time it takes for an idea to kind of percolate and reach the mainstream. Yeah. And so whilst, CBT, if we take CBT just as one example, is relatively new. It's only been around in its infancy since the 60s, and in the mainstream perhaps since the 80s, and that's in mental health. So if we're thinking, the amount of time that idea might take to translate from mental health care into physical health care, it feels like we're still charting relatively new territory. So yes. I think that's the new thing. So it doesn't feel bizarre to me to be here talking to you, because I think there's a real relevance to the world of psychology in terms of its relationship to the world of physiotherapy. Absolutely, and I think you've hit the nail on the head in terms of it's almost a shame that it would be considered new. The fact that sometimes there has been this separation for us as physiotherapists to not consider the whole psychological being and the context around that. So I know from my own experience, and also from regular discussion with multiple different professions, that there's times that professions can be protective of, shall we say, their clinical turf, especially when it comes to certain interventions. And as a psychologist, are we somewhat treading on your toes when we integrate more psychological consideration into our reasoning and then our treatment? It's an interesting question, and I think it's probably something about which there would be a range of opinion if you surveyed psychologists. Psychology can unfortunately be a somewhat ivory towerish discipline at times, and I think there are some psychologists who don't want anyone who isn't a psychologist delivering anything psychological. Okay. If that's not too many uses of psychology in one sentence. But and I think there's an interesting thing happening at the moment in the provision of NHS services. So the course that I run here, which is training people to deliver psychological interventions in primary care. Most of those people that I'm training aren't psychologists. They're people from other kinds of backgrounds, for example, nursing, social work, occupational therapy, who are training to be CBT therapists. So I think one of the things that's a current factor is that the provision of psychological interventions is becoming much more diversified. And in my view, and this is only my view, but I think that's a very good thing, because I've no interest in building walled gardens, if you like, where only certain people are allowed in, or only certain people are allowed access to certain bits of knowledge. Because I kind of think if you found something really useful that could bring relief to lots of people, why would you keep it secret, or why would you limit it to the chosen few? I would be happy if we wound the clock forward a few years and all physiotherapists were much more kind of psychologically informed, because I think it would be a more rewarding experience for them. And I think, and again, if with reference to the evidence about what it is that stands in the way of people's effective recovery, I think it's going to be in the interests of patients.
No, great stuff. And I mean, by the vast majority, there's a consensus that the use of psychological interventions as physios should be embraced on a number of levels. But as I've personally delved into the types and styles over the last few years of my own practice, I can understand why it can be considered a muddy swamp, particularly filled with acronyms. I mean, CBT, NLP, ACT, MI, DBT. I mean, I could go on. I mean, they're the ones that I've personally been exposed and somewhat trained in. Is this intimidating swamp realistic, or is it an overcomplication of your own trade?
Well, I guess, again, in the interests of demystifying psychology, it's no different from any other industry, really. So psychology and psychological therapy, if you want to make a name for yourself in it, you don't do that just by repeating what someone else has previously done. You do that by changing things, adding something different, giving it a new brand label, developing your own brand of treatment. So, to a certain extent, there's a game being played with regard to empire building, but there are lots of different ways to look at the same problem. So in psychology, there are various different schools of thought, as I'm sure there are in physiotherapy. Absolutely. About how you might go about delivering the core business, which I would see as sort of increasing psychological understanding and reducing psychological distress. There are lots of different approaches to that. And I can see how that might seem very hard to navigate, and it might seem quite intimidating for people that don't understand it. And I guess if I were a physio with an awareness that I wanted to increase my psychological knowledge, I probably wouldn't know where to start, because there's so much stuff out there. And in a profession that kind of prides itself on scientific integrity, having lots of different explanations for the same thing isn't really a great position to have, because it makes it very difficult for people to try and work their way through it. I'm kind of struck in answering your question by something that one of the people in psychology that I very much look up to once said. This is a guy called David Barlow, who's a cognitive behaviour therapist, and has been through the whole thing, right from the implementation of behavioural therapy in the 1950s to the what we'll probably talk about later, third wave CBT interventions now. And he said recently that in the future we just won't be talking about models of therapy. We'll only be talking about evidence-based practice.
Right.
That will really be the only question. Not what's this called, or how does it work. It's just, does it work? And I think that in the context of that, there are certain things that are coming to the fore. So my advice to physiotherapists wanting to become more interested in psychological intervention would be to just focus on the evidence base. And most evidence in physical healthcare comes from the cognitive behavioural school. It is very possible to get completely distracted by a particular brand, and I'm always slightly suspicious of people who absolutely nail their colours to one particular mast, because I think when you do that, it perhaps blinkers you to the fact that other things might be coming up on the horizon that are useful. I mean, speaking about myself and my practice, I'm really only interested in the things that have been shown to be effective. Because I'm a taxpayer, and I think that if we're going to be providing services on the NHS, for example, I think there's a duty for us to think about provision of things that have been shown to be effective. If I was a patient, and I have been, and I'm sure I will be in the future, if I had to choose between something that has been shown to work or something that may well work but we don't know whether it does or not, to me that's a no-brainer. I'm always going to pick the first option. So I think people can get distracted by brand names and celebrity and all of those kinds of things, It's why I think, Adam Meakins, when he spoke to you, made some really interesting points about critical thinking, that it's a really important skill to have, that you can interrogate the evidence base and then you can choose for yourself what seems like it's been effective in the past, and then you can choose to then integrate that into your practice.
Absolutely. No, that's a great point. And before we get into certain styles and interventions, it is worth acknowledging that at an MSK clinic level, for various reasons, patients can sometimes become a bit disgruntled by the fact that we as physios might use psychological interventions. And so is helping a patient to understand the place for these techniques and for the place for professionals like you a good place to start, shall we say?
Yeah, I think that's something where one also might reasonably expect a range of responses. If I get what you're saying, if you approach a patient from a psychological perspective, that might not be something that they're expecting. And their response to that is likely to depend on their worldview. It's precisely the same issue in psychological intervention in mental health care. So that there are some people who really are interested in engaging in a psychological intervention. There are other people who just want to take medication. So if there's a choice between 12 sessions of CBT or taking an antidepressant, there are some people who will take the antidepressant. It's much easier.
Yeah.
There's not much effort involved in sticking a pill into your mouth. Engaging in 12 sessions of CBT, on the other hand, is a much more effortful endeavour. And so there are people that will have different sort of frames of reference for what they think is going to work, and then people that have very different approaches to the amount of effort that they want to put in terms of ameliorating their difficulty. So, I think there are going to be some people that will embrace anything that will help them to recover. Some people are so desperately distressed by their current experience that whatever you do will be well received. There are some people that, just because it chimes with where they come from and how they see the world, they'll embrace a psychological approach. Equally, I think you have to be prepared for the fact there's some people who just run a mile, either because that's just who they are, they run a mile from anything touchy-feely, for want of a better expression,
right.
and some because it's not what they signed up to. They went to see a physiotherapist, and here you are talking to them about their thoughts and their feelings that they might think, what's going on here?
Yeah.
I think there's also an issue that the psychological and mental health side of our suffering is somewhat misunderstood still, and I think there is a reluctance on the part of some patients and probably some physios as well, that anything that's not in the apparently physical world is therefore not real. If that makes sense.
It does, yeah.
There's a great quote from it's from Harry Potter, actually. It's the headmaster of the school, Albus Dumbledore. He says to Harry, "Of course it's happening inside your head, Harry, but why on earth should that mean that it's not real?" Which I think is a really interesting quote. If we consider our experience in the whole, then we contact the world in a number of different ways. Physically through our senses, but psychologically through our interpretation of what happens and through our application of language. So, whilst we might be getting a bit philosophical here, I think there's a real issue that any situation that somebody's in, and if they're in a situation that requires them to go and see a physiotherapist, that situation is going to comprise of a number of different variables. And just because you can't see some of those variables doesn't mean that they don't exist, or they're not real, or they're not having a huge bearing on the situation. And I kind of think that as physiotherapists, it's probably you probably have a duty to inform people that the physical side of things is really only half the story. And if I can quote someone else, Gordon Waddell in his book Back Pain Revolution made the point that cognitive and behavioural risk factors are more important than physical risk factors in predicting the development of low back pain related disability. So it just feels to me that psychological factors are clearly part of the problem, and that's been shown over and over again in the literature. And therefore, psychological interventions should probably equally clearly be part of the solution.
Yes.
And a biomedical model on its own just doesn't cut it. And I think that we probably have a duty to inform patients that that's just how it is. And probably we should tell them that from the off. So in short, yes.
But so could we go into explaining some of the differences and similarities between the techniques that I mentioned earlier and also others in the industry that I might not have said?
Yeah, I mean, this could be a very, very long answer. So I think in the interests of keeping the listener awake, it might be best to kind of focus it. I think perhaps I'd like to talk about three things, if that's okay.
Absolutely.
Motivational interviewing, cognitive behaviour therapy, and acceptance and commitment therapy. And again, my choice of those is guided by the evidence base for those interventions in physiotherapy, if that's all right.
Please do, yeah.
So I'll start with motivational interviewing. It's a psychological approach which is aimed at helping people to get to the point where they make a decision to change because they want to. So it's about helping them to facilitate their own change that's internally driven rather than externally driven. If I might use smoking cessation as an example, I mean, if one thinks about smoking, it's kind of cigarettes are a consumer product that kill half of their consumers. It's insane that it's legal. But most people know that. Most people who choose to smoke know that, and they know that there are various physical health risks associated with it. Yet they continue to smoke. So one might imagine that a useful intervention for smoking cessation would be to tell people about all the dangers. But that's generally shown to be pretty ineffective because people know it already. And so what the theoretical background to motivational interviewing assumes is that most people, when they are faced with a potential change situation, are in possession of knowledge and attitude in both directions. In short, they're ambivalent. They have something that tells them change and something that tells them stay the same, and that the reason they perhaps haven't made moves in a change direction is just because they've not resolved that ambivalence yet. So motivational interviewing is a technique to help people facilitate talking about the change part of that kind of balance, and then to use that to mobilise their internal motivation to help them change and to translate that internal motivation into some kind of goal-directed action. Mm-hmm. In my view, and this is other views are available, that I think a course on motivational interviewing should be week one of any health-related professional training. So if you're a physiotherapist, it would be very helpful if people did that before they did anything else, because you could be the most skilled physiotherapist in the world, but if the patient is not in a position where they want to make use of what you have to offer, then you're wasting your time. So a skill that helps you mobilise the client's own sort of internal motivation to make change, I think is a hugely useful skill. There's an old joke in psychology, if you'd indulge me for a second, but it's how many psychologists does it take to change a light bulb? And the answer is one, but the light bulb's got to want to change. And it's a joke, and it's old and it's cliched, but there's a lot of truth in that. That people will only go where they want to go. Really, you can't make people do things. And I hope I don't mean to sound at all disparaging, but what I've noticed in some of the experiential exercise I use in my training courses with physios is that they're incredibly good at giving advice. And so if we do an exercise whereby they are asked to just ask questions, elicit information from the other person engaged in the role play, within about 30 seconds they'll be giving advice. And it'll be very well-meaning advice, and it'll be, if you tried this, you should do this. Why don't you try doing that? And that's great. And I'm not trying to say there's no place for advice, but I think there's also a place for just eliciting information from people and exploring their motivation before you hit them with the advice.
I think it rings a bell from a course I went on that is that a curative reflex almost, that people almost have this burning desire to express advice on people if they feel they have it.
Well, yeah, without sounding too much like a psychologist, I guess we all have our own reasons for why we entered the profession that we entered. And if you found yourself in a health-related profession, it's probably because you have a kind of quite a strong motivation to want to help people get better.
Okay, yeah.
And if you're in possession of a knowledge that you think is going to help them, then it seems intuitively reasonable to tell them that knowledge, and then tell them what they need to do in order to change. However, if, for example, you wanted to give up smoking and I just hit you with a load of facts about why you should do it, there's a fair chance that you're going to become quite disengaged from that process quite quickly. If I sat here and spoke to you about why you wanted to change and maybe what reasons there were for you changing, if I asked you how you thought you might be better off, if I asked you what steps you'd already taken in that direction, I would say there's a fair chance that would be a much more engaging conversation, and that would create the context for me to perhaps give you some advice a bit later on down the line.
Fantastic. And on motivational interviewing then, just to try and share a bit of my experience with it, is one of the most powerful things it did for me was to try and help me to understand the position and place that someone was in terms of readiness for change. It also helped me to then not almost burn out by this advice giving to people that might not accept it, and tailor my interventions for people that were ready. Do you think that's something that, not just for physiotherapists but all healthcare professionals, knowing when to pitch what is part of that motivational interviewing skill?
Absolutely, yeah. And it's not an easy skill to develop. I certainly feel like I'm still learning that after many years of practice as a psychologist. But assessing people's readiness and pitching the right thing at the right time is definitely a really key skill to have. But as I say, not an easy one to develop. An old boss of mine used to say, it might only take 6 sessions to really turn somebody's life around, but you may well have to wait 6 years for that opportunity, and that's an important
Wow.
point.
Yeah, and so that's the thing. And if you were to constantly feel like you were hitting your head against a brick wall, it would burn you out, disinterest you as a therapist, and certainly as a patient. So that's a great point. And so and obviously it is a seamless link into CBT, but would you say there are any textbook differences between motivational interviewing and then into CBT?
There are differences. Yeah, I think that motivational interviewing is best viewed as a component of treatment that facilitates the treatment, if that makes sense. Yeah. So I use motivational interviewing as part of CBT. So it's kind of the first thing that I might do with a client, to explore with them whether or not they want to engage in CBT, and to perhaps go through the pros and cons of that process with somebody.
So there's a pre-CBT intervention almost.
Absolutely, yeah. And I think there are some recent, going back to David Barlow, he's just come up with a protocol for working in mental health around primary care mental health issues such as anxiety and depression. And this is based on a long period of research trying to identify what are the active ingredients of CBT. And module 1, surprise, surprise, is a motivational interviewing module. It just seems intuitively sensible, and now the data backs it up that's where you start with people. You explore whether or not they're in the right place psychologically to benefit from this intervention, and I see no reason why that doesn't apply equally to physiotherapy.
Yeah, I every podcast I seem to digress into metaphors, but I know I've discussed before, it's about finding base camp sometimes, and without finding that, where's the journey going? With the third thing that we mentioned of those three main ones, and I'll be honest, they would probably be the three most pertinent and most, as you said, evidence-based, especially in physiotherapy, is ACT would be the third one. Where's that maybe come from? Is that I've heard of it more recently, or is that my own previous ignorance? Is it more recent?
No, it is more recent, yeah. If I could talk about CBT and explain in terms of the historical development where ACT comes from, that might make more sense to the listener, because it is a much more recent development. Mm-hmm. So if we can maybe move on to CBT, I mean, people often think that CBT is a thing. Cognitive behaviour therapy is one thing, and it's not really. It's a school of thought. And CBT is best thought of as an umbrella term to describe a range of interventions, all of which have tried to, wrestle with this core question about how do we alleviate psychological distress for people. It's best thought of as being something that kind of consists of three waves or three phases, and it's often talked about in terms of waves. So the first wave is behavioural intervention. So this would, going back on a little history tour, people may have heard of people like Pavlov. So Pavlov's dog, people often know about. So what Pavlov was interested in was trying to understand why people had phobic responses. So why were people scared of things that weren't scary, right, essentially? So why do people have spider phobia, for example? Yeah. And he was interested in looking at what happens when two stimuli get paired together. So his famous dog experiment was that he would feed his dog, and at the same time he would ring a little bell. And what he noticed was, after a while, that he only needed to ring the bell and the dog would start to salivate as if the food were present when it wasn't actually present. Mm-hmm. So the dog had associated these two stimuli, and it would respond to the second one as if the first one were present, which helped him to understand why people become fearful. So if we think about chronic pain, for example, I guess many physios have been in a situation whereby they've perhaps suggested an exercise to somebody and immediately that person has become anxious. They've not actually done the exercise, you've only been talking about it, but the anxiety is present, as if the exercise were being done. And that's because people have paired those stimuli, they've paired pain and anxiety together, and merely talking about a situation where pain might be present brings anxiety to the fore. Mm-hmm. So that was where CBT kind of started, in this very, very behavioural understanding of, if this happens and this happens at the same time, then we get an emotional response. That school of thought was taken further mainly by a guy called Skinner, who is responsible for a theory that we call operant conditioning, which is all about reinforcement. So the idea that certain behaviours will increase in frequency if they're followed by something that's reinforcing. So, if I can explain that very simply, if you punched me in the face and I straight away gave you £10, there's a fair chance that you might punch me in the face again. If on the other hand you punched me in the face and I took you down with a bunch of high-skilled karate moves,
maybe later, not in front of the expensive equipment, please, Richard. But all right,
you'd probably think twice about punching me in the face again.
Absolutely.
So it's very simple, and it's just the idea that behaviours increase if they're rewarded, and they decrease if they're punished. So that work feeds very much into modern CBT and thinking about why certain behaviours are maintained. So there might be certain things that are going on in a person's life which we would look at and think, well, why are they still doing that? But usually, if someone's continuing to do something, it's because it's being reinforced somehow. And I guess coming back to physiotherapy, there are probably examples where people don't do the things that you've recommended them to do. So you see them, you suggest to them, if you do this, good things will happen. But they don't do them, which is kind of curious. Why wouldn't you do something that's going to make you better? But there may be very other important reinforcing factors in that person's environment, which means that actually it's not in their interests. So, for example, if you have a person who gets something out of being dependent, so if they have a relative that runs around after them doing everything for them, that it's not really in their interest to become more independent. Yes. It's because they find maybe the attention or the nurturance or the care they get from somebody else very reinforcing, so they don't then take steps to becoming more independent.
Often without them realising that as well. That it's not always a conscious thought process that goes on there, is it?
Yeah, that's right. We don't want to paint people as being kind of openly manipulative. It's just that we are all of our behaviours exist within our context, within our our environmental context, and sometimes we're not aware of those links. So there's that work. But then what happened next? So the second wave of CBT, or what's sometimes called the cognitive revolution, was really based on the notion that you might have the same stimulus, but it produces different results in two different people. So if, to take something that's kind of not close to my heart, if we started to play a Mariah Carey track in here, I would quickly leave the room. Maybe you wouldn't. The same stimulus does not affect people in the same way, and equally, there may come a time in my life where I openly welcome listening to Mariah Carey, so people change their minds over time. So the same stimulus for the same individual at different times produces different responses. And
interesting that in our brief meeting you've branded me a Mariah Carey fan as well, Richard. There's an interesting psychology behind that, maybe.
Yeah. Well, I'm doing my thing, manipulating you in various ways that won't become fully apparent to you till weeks later.
Maybe.
Yeah. The notion there was that there must be something else going on. There must be another mediating variable. So the cognitive side of CBT is really just the notion that it's not. People aren't distressed by things. They're distressed by the view that they take of things, and we know that to be true because if you look at a bunch of people that experience a natural disaster, for example, some of them will really struggle psychologically. Others of them won't. They've been through exactly the same process, but the way that they appraise it is different, and that has an influence on the way they feel and the way they behave. So what the work of the cognitive theorists and the names there that people might be familiar with are Albert Ellis and Aaron Beck particularly. What that brought to the table was this notion that there's a mediating variable. So we can change the way we feel about things by scrutinising the way we think about things. So there's this relationship, this reciprocal relationship between thoughts, emotions, and behaviours and physiology that's very pertinent to physiotherapy. I note that people talk very much about this concept, fear avoidance. Before I started getting into the physio work, I wasn't familiar with that term, but what that term does is to link these two things together. So, where you have anxiety, you tend to have avoidance. It's the action tendency, if you like, of anxiety to avoid things.
Yeah.
If you're scared of spiders, don't go down the garden. It's a kind of intuitive link. So that's what the cognitive theorists brought to us, and it's often phrased in terms of an ABC model. So there's an A, there's an activating event, there's a B, there's a belief about that activating event, and it's B that shapes C, the consequence. So the emotional consequence, the behavioural consequence, and so cognitive behavioural therapists are very interested in this content of B. So what is it that people think? What is it that people believe about the situation that they're in? And understanding that is really key to understanding their distress. So this is a very recent development. So there are a bunch of what are referred to as third wave CBT therapies. And it's a kind of difficult thing to explain, but this ABC model, what it really points you towards is if you can change B, then you might be better off in terms of your distress. So, for example, if you have chronic pain, and what you tell yourself about that chronic pain is that I shouldn't have it. It's unfair. I shouldn't have been put in this situation. It's awful, and you have kind of catastrophic views about it. Or you tell yourself that you can't stand it, or you tell yourself that you're somehow less of a person because you're suffering from this and other people aren't, or you're never going to be the person you used to be. If you believe those kinds of things, that's pretty much a recipe for distress. Mm-hmm. In comparison to someone else who might believe, I would really like for this not to be the case, but it is the case. It's bad, but it's not awful. It's not the worst thing that could ever happen to me. Mm-hmm. It's really hard to bear, but I can bear it. And it doesn't diminish my worth as a person that I'm not able to do some of the other things I used to do. There are new things that I could do, perhaps. That person is likely to be better off in terms of their approach to their physiotherapy, and I would hazard a guess that person's probably likely to recover.
That's certainly where the physiotherapy evidence points to, in terms of outcome. Yeah.
So that kind of second wave CBT notion would be that, well, let's change people's thinking. So let's try and identify what the problematic thoughts are, and let's devote some attention to trying to change them. Change those thoughts into more kind of adaptive thoughts. Yeah. But the third wave takes a different view. So it's not trying to change the content of people's thoughts. It's similar. So they would agree with the ABC formulation largely, but the intervention would be different. So they're not trying to change the difficult thoughts. They're trying to encourage people to become more aware of them, but to be more accepting of them, and to, if you like, change their relationship with the thought rather than change the thought itself. Okay. So I think that one of the notions that's important here is that if you start to label something as bad, so that's a bad thought or that's a negative thought, you're starting to describe it as a symptom, and then the inference there is that there's kind of something wrong with you, and that you should be getting rid of that. And the third wave people, they're not comfortable with that notion. Okay. What they would believe is that that's quite a normal thing, really. Right. That if you're in a very difficult situation, there's a fair chance that negative thoughts will come to the fore. However, you don't need to let those thoughts run your life. Right. There may be a way that you can notice that those thoughts are present, but just become more accepting of those thoughts, but decide not to listen to them.
And that will then influence the output, the consequence.
Yes. Right. Yeah. So if we could have an example, maybe let's take that same person who has lots of negative thoughts about their physiotherapy intervention. Yeah. The third wave approach would be to encourage people to become more aware of what they think and what they believe about their situation. But let's say you have a thought that says, I can't do my exercises because they're going to hurt. Mm-hmm. If you think about it, the alternative to that might be, I can do my exercises and they're not going to hurt, but actually that might not be true.
Yeah. Don't know the line.
So maybe you, going back to that second wave CBT notion, maybe there's not much mileage in trying to challenge that thought because it might be true. Okay. So, if I do these exercises, they're going to hurt like hell. Maybe they will. But if you let that thought run your life, then you're not going to do the exercises, you're not going to make improvements in your physical condition, and other things that you might want to do in life are kind of getting further away. So maybe you could do them, maybe you could learn to tolerate the discomfort, and kind of, work your way through it, and still take steps in your valued direction.
Okay.
So there's a difference in terms of trying to achieve the same aim, but trying to do it in a different way. So not changing the thought, but changing your relationship to the thought.
And where's the evidence swung in those two things?
Well, we're in somewhat new territory. If we take acceptance and commitment therapy, referred to as ACT, the first ACT textbook came out in 1999. So where are we now? 15 years on from there. There are something like 75 randomised controlled trials as of now that support the use of ACT across a whole range of different conditions, and a number of those relate to chronic pain. So in the US, they have a slightly different concept. We have NICE guidance here. In the US, there's this notion of empirically supported treatments, and ACT is on the list of empirically supported treatments for the treatment of depression and chronic pain.
Right.
And it's approaching that kind of significance for the treatment of some other conditions too. So I think the most established evidence is for CBT, that more traditional second wave way of working with things. Challenging, looking for the evidence for thoughts and trying to challenge ones that aren't helpful. But ACT is coming up fast on the outside.
Okay.
So I can envisage a position quite soon where those two different approaches to the same question will be viewed as having more or less equal efficacy.
Right. And has there been side-by-side RCT, I hate the term battle in research, but has there been good quality studies comparing those two interventions in which there's been a significant difference between them? That kind of work is starting to be done, but I wouldn't feel confident about giving you any clear answers to the question as of now. I think that's something that will unfold. Right. Okay. So that's ongoing. It's not being actively avoided then, because sometimes those things that have such similarities, sometimes people struggle to put them against each other, shall we say? Yeah.
No, there are one of the good things I think about both CBT and ACT is that the people, the proponents of it, are very much aware of the need to establish evidence.
Okay.
There are some other psychological therapies where that kind of scientific approach is much less stressed, but with regard to CBT and ACT, ACT really is a CBT. It's within that umbrella.
Yeah, of course.
There's a real drive to try and work out not only are these things effective, but do they work for the reasons they're supposed to work. So there's lots of mediation analysis, for example, in looking at, can we say that the outcome is due to the variables that we think we're targeting.
Yeah, that mechanism of effect that often is the very tricky thing.
Yeah. The view that dominates ACT is that human suffering is normal, really, and that might be very disappointing to listeners. But if you know someone that's never experienced psychological distress, that's never been anxious or never been unhappy, then I'd quite like to meet them because I want to know what the secret is. It seems that for most people, a range of emotional experiences is natural. So people will vacillate between feeling happy, sad, anxious, angry. And that human distress is it's a part of normal functioning, and it's facilitated by our use of language and human cognition. So we're kind of unique in the animal kingdom in terms of our ability to attach meaning to things. And that's a good thing, very helpful, and it's probably helped us to establish our dominant position on the planet. But it's a double-edged sword in that it also means we can attach distressing meaning to pretty much anything. So we have this ability to distress ourselves about pretty much anything, and that's just it's normal. But that we can, if we can learn to become more accepting of that, and learn to learn not to let this sort of constant mindy self-talk that goes on, not to let that run our lives, and to try and contact the world and use our direct experience as information rather than what our mind is telling us. Mm-hmm. If I give you an example, I'm working with someone at the moment who has a problem around social anxiety. So if this person goes into a room, that's them going into a room of people. That's what's true about it in terms of the physical world. But if she goes into a room full of people, there's a whole bunch of other stuff that comes along with that. So what happens to her is that she'll experience a lot of thoughts that these people are going to judge you. They're going to look at what you're wearing. They're going to look at how your hair is. They're going to make all sorts of negative judgments about you, and they're going to find you wanting. So she can't contact that experience as it is. She contacts that experience as her mind tells her it is. And as a consequence, she doesn't socialise and she misses out a lot. So the work there is about just trying to notice that those thoughts are present, but not letting them dictate to her.
Okay, and that's the middle ground then, isn't it? That acceptance almost on our level as therapists that's normal. It's a scary phrase to use sometimes, but helping people to embrace the fact that this is within the realms of normal, and it's about adjusting around that. Yeah.
The other idea that comes along with that is that it's not that's the enemy. So it's not pain, for example, that's the enemy. It's the struggle with pain that's more likely to get you into trouble. Mm-hmm. So trying to escape from your internal experience is generally not associated with good outcomes. Mm-hmm. So people who invest a lot of energy to try and not feel pain or to not be anxious, it generally doesn't work out well for people, because what they're doing kind of counterintuitively is that they're putting their pain front and centre, that they're making that the focus of their life, or they're putting their anxiety centre stage, and that's the focus of everything. So in trying not to be anxious, you make yourself anxious.
Of course, and that's often discussed on various podcasts we've had, where people that are spending a lot of time and money seeking therapeutic curative action, and that again heightens that sense of putting that at the forefront. So a great point. And ideally, without me having to embrace role play, shall we say, can you give examples of common roadblocks or bumps in the road, shall we say, during a rehab journey, and what tips could you give our listeners for overcoming them?
Well, I think, going back to what I was saying earlier, I think motivation is a key psychological factor. That ebbs and flows. So I think, one, it's very important to assess motivation and to pay attention to motivation early on in treatment. That's one thing that's relatively easy to do. That you, when you assess somebody, you're not just assessing their problem, but you're assessing their suitability for the intervention.
Preempting the bump in the road.
Absolutely, yeah. And then you can, if you've done that, you can then navigate a path around it, perhaps. Yeah. So I think motivational interviewing is a very useful skill there with regard to that. And short of that, I think what's often referred to as a Socratic style is very useful. So one where you're trying to, it's based on the idea that most people they have some of the answers themselves in terms of what's best for them in their particular situation, and helping them to discover what's workable for them in their lives. That's really helpful in terms of keeping motivation.
And we can't learn from patients until we can get them to tell us things. So absolutely, no, that's a great point.
The thing I often say to my clients is that they're the expert, really, not me. they know more about them than I'm ever going to know. I know some stuff about psychology, and hopefully we can put those two things together in a way that's helpful. But when it comes to what's best for them, they know more than I do.
Yeah, absolutely. Which is sometimes difficult for them to understand as well when they come to someone who's seeking expert advice. For that to be turned, sometimes it can threaten in itself. But as we've discussed, there's a number of ways around it, and I completely agree. The preemptive strategy of trying to identify the roadblocks before that they're there is a great way to start. And would it be fair for me to say there's an argument that especially in physiotherapy, partly because of our historical, more biomedical ethos, in that talking therapists can sometimes shy us away from saying it as it is, and being a bit warm and fluffy. And sometimes I must admit my own bias and say my experience is it does exactly the opposite. But if you were to coax both the questions and the answers from the patient, it can be helpful. Do you think we do talk around the issue if we're not careful? And are we shying away from saying the harsh reality?
I think this is an interesting thing. I wasn't sure that I agreed with the premise of the opening part of it. Because I think some people can see talking therapy as kind of like a soft option. So if we talk about this, that will prevent us doing some real work, kind of thing.
Yeah.
But I just don't think that's the case. I think if you talk about the psychological aspects of a problem, what you're doing is promoting an honest exploration of the reality, and some of the reality won't be very pleasant. So I don't think it's a soft option. You ask anyone that's been through psychological therapy how easy that was. Most of them will tell you it's pretty difficult. So once you start opening up some of these issues, so you might see someone who's anxious about doing some exercises. You start talking to them about that, it may well be that it's not just the exercises they're anxious about. It's a kind of a personality style, and there's all sorts of areas where they struggle. So it's not an easy option. There's a saying that I use quite a lot. It's funny that I'm talking to physio, but therapy's not a massage. It's hard work, and it's not necessarily meant to feel nice. Where I think that some people who learn about psychological interventions can get a little unstuck is that they focus too much on trying to help the person in front of them feel better rather than get better.
Absolutely.
If that's a useful distinction.
It is certainly in our industry. It's as pertinent as any. Yeah,
that you can start to collude with people's anxiety. It's very easy. Anxiety is very infectious. People start to talk to you about how anxious they are, then intuitively, if you're kind of a nice person, you don't want to push them, you don't want to put them in a situation where they experience lots of anxiety. But I think I would want to be quite clear about this, that if you start to introduce psychological aspects into the work, it's not going to make it easier. It's going to make it more complex.
Absolutely.
And perhaps less comfortable for the patient, but I think ultimately beneficial in terms of being more effective and a more rounded piece of work.
I am being a very difficult devil's advocate when I say there is this argument of getting people just why are we doing this, why are we going around it this way, we should just tell them to man up, for example, and it is petty, I agree, but it is out there to some degree. And do you think that that's a society thing? Certainly something that's present in the media. There isn't a lot of respect sometimes for these things that we've discussed.
No, I think you're absolutely right. I think there's still a real stigma around the psychological aspects of our functioning. I think it's improving. So I think that, going back a few years, when I first got into psychology, I was trying to explain what I was doing to my nan. I was trying to get her to understand what this thing was that I was, going to spend my whole career doing, and she just didn't get it. Just didn't understand it. But you got to understand, her formative years were during the war, and there's just a very different approach to how people dealt with adversity. But I think that over time we've become much more kind of understanding about the psychological aspects of human functioning, and that's much more understood now in terms of the way mental health care is approached. And I think it's becoming much more well understood in physical healthcare, but that will take a little bit of time, for those ideas to really kind of percolate and influence what happens.
Yeah, certainly. And we can only, shall we say, try and promote the good word, or promote where the evidence sits, and almost not just cross our fingers, but allow for time to pass and not get disheartened by the fact that it's not embraced by every newspaper, every outlet, every broadcast medium. So no, that's a great point. And finally, how would you direct any of our listeners to access and find out more about the topics that we've discussed? And also, do you have any shameless plugs of how people can hear from you personally?
There's a number of things. This is probably a shameless plug, but I would direct people to your earlier podcasts. I think over the course of 2 very informative hours, Mike Stewart made an incredibly eloquent case for integrating psychological elements within physiotherapy practice. I started listening to that as kind of a bit of revision for meeting with you, and I could not stop listening to it. I thought it was an incredible piece of work. And he in there mentions lots of other places where people might want to go and look. In terms of the sort of empirical side of things, there's a lot of good work gone on at Warwick. So if people want to look up the work of Zara Hansen and Sarah Lamb, there are some papers around the 2010 era about the use of CBT in a group setting in chronic pain. A more recent publication is really hot off the press as a book by a guy called Mark Carlson. So it's a 2014 reference. The book's called CBT for Chronic Pain and Psychological Wellbeing. The entire book describes a treatment protocol in great depth. So it's a sort of step-by-step approach to integrating motivational interviewing, CBT, and ACT into a treatment program for people with chronic pain. As for myself, here at the University of Birmingham, we run quite a wide program of continuing professional development opportunities. Which includes basic training in CBT and ACT techniques. And then there's the work that I'll continue to do with Jared Green up and down the country, offering 1 and 2 day trainings for physio, specifically targeted at physiotherapists in terms of developing their awareness of psychological intervention.
So that leaves me and the opportunity to tell the listeners that we will be compiling a show notes newsletter which will have access to some of the references that you've just mentioned, as well as some information about yourself. But finally, thank you very much for having me today. Absolute honour and pleasure to come and talk to you, and I hope again we'll be able to cross paths again soon.
No problem, it's been a real pleasure. Thank you.
And there we have session 9. Huge thanks to Dr Richard Bennett for his time and to the MACP for their support. As with all of our podcasts, an hour is nowhere near enough time to cover a clinical entity as thoroughly as we'd like. So please look at the resources posted on Twitter and in our show notes newsletter for more depth and insight into today's topic. Having the chance to question experts such as Richard is a huge privilege, and so I might as well share what I think are the key take-home messages for frontline clinicians such as me. When bridging the gap between assessment and treatment, identification of a patient's readiness to engage with what you feel is necessary is vital. And for this, the evidence points us towards the use of motivational interviewing techniques and to avoid nagging patients to change or even threatening potential consequences on them, which although it's inadvertent, it does remain commonplace. When we get into comparing CBT and ACT, I could be in danger of oversimplifying things, but I am feeling brave. So if I try to give a more traditional exercise-based example that I suspect most in the MSK game would be pretty comfortable with, if as a physio you assess what you deem to be a dysfunctional or suboptimal movement pattern, your clinical reasoning might lead you to trying to improve or at least change it. If you replace the movement with thoughts and beliefs, then this could be considered a CBT-like technique. Alternatively, your reasoning might lead you to training the patient to improve their tolerance and capacity for said movement. If you help them to understand that they move that way as an individual and that it needn't be a problem. Hopefully I haven't lost you if I was to suggest that ACT is like this, but for psychology. And as in my movement example, it is usually a combination of both, so we're better off embracing both. And so for the plugs, if you were to follow at CBT_UOB for tweets from Richard's department, at Physio MACP for debate and discussion around all things MSK, and of course I'm at Choose_Health with the Whittier podcast team tweeting from at TPM Podcast. A final plug is for the MACP conference on October the 25th, which this year is on exercise rehab and patient engagement. Sign up online, macpweb.org, and I shall leave you with Richard, who's going to see us out.
So you've been listening to the Physio Matters podcast, discussing physio matters because physio matters. Less Gorgon, more Zola.